Thank you so much, Dr. Chawla. At the outset, I would like to thank the DM-IDU team, Dr. Mohan and my dear friend Anju for inviting me yet again for this very, very prestigious conference. So, interestingly, my topic is about should we have remission as an management objective. So I'm not going to delve into great detail about how remission is done, what it is done, but whether we should actually have it as a management objective is what I'm going to delve into. So this is the traditional view of type 2 diabetes as a chronic disease. All of us have been taught, even in medical school, that it is a lifelong disease, a chronic disease, and there's nothing you can do about it other than control it and control it well. So most medical professionals and patients focus on this, and they want to treat diabetes in this fashion. And this is the standard management approach that we have, where there is multifactorial, there's behavioral therapy, there is diet therapy, and then there are drugs that are there, more and more newer ones that are there. And this is how the standard management approach is. And to add to that, the famous UKPDS is there, which told us that it is a progressive disease despite what you do. And therefore, this entrenched view has created significant resistance to adopting something like remission, because it's relatively new. Anything new, always there is a resistance. And there are proponents and opponents of the view of remission. What's the use? Weight comes back. The patient again gets diabetes and all of that, but let's just look into that a little bit. These are the differing approaches to diabetes management, but what you'll see here is one common thing, and I put ADA and EASD as the Western view and the JDS and the KDA as the South Asian view, and you will find that all of them, either they look at the pathology of diabetes or they look at the comorbid conditions, and that's how they treat diabetes. And there is nowhere you will find that remission is a management objective. You don't find that here. You look at comorbid conditions, even the ADA EASD tells you that if there is ASCVD risk, use GLP-1. If there is kidney disease risk, use SGLT2. So everything is around that. But do they go to the root of the problem? And what's the root of the problem? The root of the problem is obesity, insulin resistance, fatty liver, etc., etc. So those are not really looked at. So these are the current treatment limitations. If you were to go for a very thorough kind of a remission, where you look at pancreatic transplantation as one end of the spectrum and bariatric surgery as the second end of the spectrum. Now you will find that in the bariatric surgery section, you will find that it recurs. It comes back after 5 years, 8 years, 10 years, whatever it is. Insulin pumps are used, and there is no innovative, as far as we can see, if you look at all the studies that have been there, which I'm going to show you in a short while, if you look at all the studies, you will find that yes, remission can happen, but relapses are common. So that being the case, should we have remission as a management objective is the question. Now these are the limitations, as you can see, of current drug-focused approaches. So in an evaluation of diabetes management drugs approved from 2011 to 2017, additional benefit was there only in 16% of patients, and lifestyle habits causing obesity cannot be solved with drug therapy alone. There are so many drugs. There are anti-diabetic agents, there are anti-obesity agents, but do they really reach the nub of the problem, and that is behavioral therapy? It does not. So drug approaches cannot be applied to everyone and maintained for a lifetime. That is another thing that we are seeing, everyone asking us about anti-obesity medication, how long do we take them? So the over-reliance on pharmacological approaches may be limiting healthcare professionals' consideration of remission-focused strategies. So we are so dependent on anti-obesity medication. We are so focused on comorbid conditions and their treatment that remission really doesn't enter in the routine practice. It does not enter our heads that maybe that approach in the relevant cases. I'm not saying it's for everyone, but that approach is something we never look at. If you have a patient who has just walked in and he's just been diagnosed with diabetes in the last 1 week or 2 weeks, what do? We look at his HbA1c, we look at the osmotic symptoms. If he's very symptomatic, we may put on insulin and then switch to tablets or start with tablets alone. Does remission even enter our heads in newly diagnosed type 2 diabetes? And that's the question here as to whether we should use it or not. Now let's understand diabetes remission a little bit. So definition of remissions, I'm not going to say which one is right, which one is not right, but the usual definition is fasting blood sugar of 126 or A1C less than 6.5 for at least 3 months without hypoglycemic agent. This is a very simplistic kind of definition of remission of diabetes. Now whether it is the correct one or not, that's up to debate. The pathophysiological basis now of remission has been very well elucidated by Roy Taylor's twin cycle hypothesis. It explains very clearly how excessive energy intake causes type 2 diabetes, and if you do the reverse, if you do energy restriction, it can lead to remission, as simple as that. And the evidence for that is the seminal study, the direct study. Many of them were then repeated elsewhere, and the direct study showed that if you have a structured program in a non-surgical way, non-pharmacological way, behavior change intervention for initial weight loss can achieve remission. So this is something that we got. One moment. Yeah. So despite this established framework, remission remains underutilized. I just told you that when a new patient with just type 2 diabetes, maybe 35, 40 years old, walks in, we never even think of remission as the first line of treatment. We are always looking for comorbid conditions and all the other things, and then we are going to take this. So it remains underutilized as a treatment goal in clinical practice. Now comes definition and the limitations of those definitions. Please understand that A1C below 6.5 and without any medication is the definition. Now, is this really realistic? So, year before last, I always like to say that Julio Rosenstock gave a beautiful lecture in the ADA where he likened diabetes remission to cancer remission. Now, when you have cancer remission, don't you give a maintenance therapy to the patient, even if you call it remission? In the same way, for diabetes remission, why can you not have something like a metformin or any other which you actually use for treating pre-diabetes? Why can't that be a maintenance therapy? But then that doesn't fit into the definition of remission of diabetes, and that is the limitation of this. So you can see here that in 2021, the international consensus defines type 2 diabetes remission as A1C below 6.5, sustained for that specified period, 3 months, 6 months after starting a lifestyle intervention, or undergoing bariatric surgery, or after stopping glucose-lowering medication. Thank you. But what's the problem with this definition? You can see here that this definition is primarily glycemia focused. You are only looking at glycemia. You are not looking at anything else. You are not looking at the root cause. You are not looking at sustained weight loss and optimization of cardiovascular risk factors. That's the problem with this definition. Very simplistic, only A1C and no drugs. So that is the problem with this. So complete normalization of the underlying pathophysiology of type 2 diabetes is rare, as all of us know, and hyperglycemia recurrence is very common, often requiring reinitiation. So, next question, why are healthcare professionals resisting type 2 diabetes remission? Why do they not want to adopt it as the first line of therapy in the individuals where it is required? So, it is, as I said earlier, it is traditionally viewed as a chronic progressive disease, and although there is emerging evidence of remission, they have been very slow to adopt it as remission. There are several reasons for this. There are barriers to remission, and that is what I am coming to. So as you can see, there is lack of multidisciplinary support. So if you want a successful remission, you require a team. You require a nutritionist, you require a social worker, you require a coordinator. So you require a team which may not always be possible in every practice. Then in many countries, there is no recognized system for managing diabetes. And again, the current guidelines emphasize drug selection based on comorbidities rather than addressing the underlying cause of disease. So these are the barriers why even when it is a tenable proposition, people do not, doctors, healthcare professionals do not view remission. It's often, seen as a whim or a fancy of some individuals, but it is not seen as an actual management option, and these are the barriers. This is a very beautiful paper. Dr. Anjana is the co-author of this, and a lot of my slides are inspired from this particular comprehensive review, which came in very recently in 2025, about re-evaluating the concept of remission in type 2 diabetes, a call for patient-centric approaches. So it is undeniable that today it is one of the methods. There are patients coming and asking us, I don't want medicine, please put me into remission. So there are various methods of achieving this. I'm going to quickly go through that. So you have intensive lifestyle interventions. You had the Look Ahead trial, which involved more than 5,000 adults with type 2 diabetes, comparing intensive lifestyle intervention with diabetes support and education. And what you find here is that, 11.5 reached remission at 1 year versus 2% in the control group, 7.3 maintained remission at 4 years, and continuous remission declined to 3.5. So that begs the question, if after a few years, it's going to go so much south that only 11 goes to 3.2 at the end of 4 years, then what happens? Now the question here is that if you are in remission for any period of time, you are postponing your cardiovascular and comorbid conditions that much longer, which is a big thing. When we are talking about medicines to postpone complications, why not remission to postpone complications? And that too in a natural way. So that is the important thing to understand. So there is clinical benefit, as you see in the Look Ahead trial. Post hoc analysis was done. There was 33% reduction in CKD, 40% reduction in CVD, and benefits increased with remission duration. So this is the weight loss impact. Intentional weight loss of more than 10% and improvements in fitness confers benefits in cardiovascular disease. And you can see that participants maintaining remission had greater weight loss, greater improvements in blood pressure, etc. The next thing, that was a Look Ahead trial. These are the low calorie and very low calorie diets, as you can see here. You have the direct trial, you have the Diadem 1, and you have after the direct trial, the NHS in the UK put in type 2 diabetes remission as one of their verticals in treating diabetes. And as you can see very clearly over here, in the direct trial, what was 46% was down to 27% remission rate in the real world. So in a clinical trial, it was 46%. At the end of 2 years, it was 36%. And at the end of 5 years, it was 10%. Trust me, even that is substantial. As I said, it will postpone complications. Diadem 1 study was even better, and it was in the Middle East, and as against 46% of the direct trial, what you had was 61% remission, as you can see very clearly over here, and mean weight loss at 12 months was 12 kgs. So, as you can see in the NHS type 2, which was, I told you, in the real world, it was not a clinical trial, 27% remission rate, and you can see here the average weight loss of 13.4 and 14.4 respectively, and 58% of participants who achieved remission had baseline A1C between 6 and 6.9. So the lower your A1C, of course remission is going to be better. All the reasons for which remission happens more easily is given very well in the direct trial. So people who are not on insulin, people who are only 5 to 6 years diabetes, people who have a lesser body mass index, or a greater body mass index. So all these, so you have the caveats who goes for remission. But what I'm saying is, as a management objective, if these criteria are being met, why not at least offer this as a management objective to individuals who fit into those categories? Then you have the metabolic bariatric surgery as another means by which you can achieve remission. I don't need to go into the details. The first one is the Swedish obesity study. 72% reached remission at 2 years, decreased to 38.1% at 10 years. It's substantial. It's always going to be better than lifestyle modification. Mean weight loss was 21%, it's bariatric surgery, and 18% at 10 years. The next one was the ARMS type 2 diabetes study. As you can see here, it's a newer one. It's the largest pooled cohort comparing surgery to medical therapy. 18% remission at 7 years versus 8% in medical therapy. 12.7% remission at 12 years versus 0% in medical therapy. That is really substantial. And average A1C is 7.3 versus 7.9 at 12 years. These were type 2 diabetes patients. So this is what you see over here. The third way by which you can achieve remission. Now this is an oxymoron because you're giving treatment and you're saying we are causing remission, and that is what most people would say. So if you had to use continuous insulin, if you had to use multi-dose insulin, or if you had to get SGLT2 plus diet, these are the remission rates that you would get. The novel GLP-1 receptor, we know that has got different ways. So you can see here semaglutide 2.4 versus tirzepatide. You can see the weight loss that you get and the A1C that you get. Now somebody will argue that when you are giving medicine, how can you call it remission? And that brings me back to my earlier statement that if something is going to cause weight loss and work on the root cause of the pathophysiology of diabetes, then you are not going to call it medicine. It is a way of attaining the root cause therapy. So that is very, very important to understand, that when you give a sulfonylurea or you give something else to reduce blood sugar, you're not really working on the root cause. Remission tries to work on the root cause. In the relevant cases, I agree with that. So comparing remission methods in terms of long-term outcomes. So you can see here that cardiovascular events, bariatric surgery showed decreased cardiovascular events, while intensive lifestyle interventions showed no change. GLP-1 agonists like semaglutide showed decreased events. Then comes kidney protection. Everyone talks about that. So bariatric surgery, tirzepatide, and semaglutide all showed decreased albuminuria and protection against CKD progression. Then comes liver health. All interventions decrease liver steatosis. That's why I say that when you are touching the root cause, now reducing liver steatosis actually works on the root cause of insulin resistance. So when you are using these interventions, I would say that they are means of remission. So MASH resolution can occur without worsening fibrosis. And lastly, quality of life. So all interventions showed increased quality of life measures, with bariatric surgery showing the most significant long-term improvements. So is it time to shift the paradigm? Should we be embracing remission? So early intervention. Remission requires early treatment of hyperglycemia and significant weight loss before irreversible beta cell changes can occur. The individualized approach is very important. Remission should be achieved through personalized, multidisciplinary and combined step-by-step approaches. Education and awareness important. Of course, policy changes are also very, very important. So it's time to recognize that type 2 diabetes, traditionally viewed as a chronic and progressive disease, can potentially be reversed through remission-focused approaches. So I'm not only suggesting that you do only the the direct trial type of thing. You can use any methods. So these are the future directions Potential benefits. Now, I have taken these thoughts from Dr. Anjana's paper. Potential benefits of remission focus. It brings obesity management and early glycemic control to the forefront. It acknowledges obesity as a key driver of type 2 diabetes, encourages early intensive interventions, enhances quality of life. But there could be potential harms of the current definition of remission, not remission per se, but the definition. Patients in remission often receive less attention, 30% lower likelihood of receiving all 8 recommended diabetes care, and may overlook protective benefits of ongoing glucose treatment and vascular damage from years of excess adiposity. So the concept of type 2 diabetes remission requires a paradigm shift towards patient-centered care with an emphasis on holistic disease. So it is not always irreversible. This is the current definition. You have various methods of doing it. There are landmark trials to prove it. The remission approach also improves other long-term outcomes, and a paradigm shift is needed from chronic disease control to patient-centric remission-oriented care. Thank you all very much.